Hello, I'm Lisa Martin from HORIBA Veterinary, part of HORIBA Healthcare, and I'm delighted to welcome you all to this continuing professional development webinar, the next in our ongoing series. We're very pleased to have you join us today. All of our previous CPD content on a wide range of veterinary subjects is available to watch back free of charge at any time in the support section of the HORIBA Veterinary website. Firstly, I'd like to provide an introduction to our speaker, tell you what to expect from the webinar and a little bit about HORIBA. We're very pleased to be working today with Kostas Papasouliotis, a highly experienced practitioner and speaker. He'll be discussing the principles of good haematology testing to include an outline of its role in modern veterinary practice and how accurate blood analysis supports clinical decision-making, monitoring of disease progression, and evaluation of treatment responses. You will gain an understanding of blood cell production, recognising normal and abnormal cell numbers and morphology, the use of manual and automated blood cell counting systems in practice, and when it's good to consult a friendly expert. Case examples, practical tips, and an interactive section will ensure there is something for everyone to take away. Kostas graduated from the Aristotle University of Thessaloniki and has been a lecturer and senior lecturer in veterinary clinical pathology at the University of Bristol Veterinary School for 25 years. After leaving academia, Kostas has held various senior roles, including Head of Clinical Pathology, Senior Clinical Pathologist and Scientific Standards Coordinator for a wide range of high-level commercial and academic settings. Kostas has published more than 130 scientific papers, research abstracts, professional articles and book chapters, and provides CPD regularly in the UK and Europe. He is the past president of the European College of Veterinary Clinical Pathology and currently the scientific advisor for the Vet in Progress Plus laboratory in Athens. HORIBA's veterinary business sits within HORIBA UK with expertise in many areas of scientific testing, including fluorescence and Raman microscopy, as well as particle characterization, automotive vehicle research and development and compliance testing for sustainable mobility and energy development, and small and large-scale air and water quality testing for pollution monitoring, industrial manufacturing and process control. As a well-established provider of laboratory diagnostic instruments and consumables, with our own local admin and technical support, we work with human medical and veterinary reference laboratories, academia, general practice and specialist sites. Our product range currently includes benchtop instruments, handheld meters running single parameter tests, higher capacity, user-friendly automated instruments, specific nucleic acid extraction, and the first fully integrated in-house PCR system. Here's a brief introduction. Our LaquaTwin handheld meters work in seconds on small sample volumes for individual parameters, including ionised calcium, pH and electrolytes, and all can be used patient-side. HORIBA supply and support benchtop systems for haematology and clinical chemistry testing, from occasional use to specialist large reference laboratory throughput with the benefit of a small sample volume requirement. These offer highly cost-effective solutions and bespoke options for esoteric and project testing. Exciting brand new developments in the HORIBA haematology testing technology in the UmiVet brand sees increased capability for both in-clinic and commercial testing platforms, giving even greater depth in reporting for veterinary samples. The Pocket Central PCR Analyzer is a unique, simple to use benchtop system which integrates seamlessly with any current lab provision. Within easy reach of all veterinary settings, each step of the full PCR process is fully automated and can be run by any trained member of the practice team 24 hours a day. Up to 8 samples are processed simultaneously, with results available in just 85 minutes, speeding up diagnosis times, informing case management and prescribing decisions, including the responsible use of medicines. The Pocket Central test range includes over 190 assays in total, enabling fast and easy testing for common and exotic pathogens across small animal, equine, farm, poultry, aquaculture and biosecurity or environmental work. Very easy PCR testing for all species and applications is now accessible to everyone. Should you have any questions during the live presentation, please write your query into the box on the screen and we'll cover as much as possible at the end of the webinar. If you're watching live and would like HORIBA to issue with a CPD certificate of attendance, please write your name and email address in the chat box on the screen and we will send these on in the next few days. You'll also have our contact details at the end of the webinar for any further queries or if you're watching back and would like to get in touch. The event recording will shortly be available to view via the HORIBA Veterinary website and you'll be sent details to enable access for you or any colleagues. So now I'd like to hand over to Kostas for his presentation on bloody brilliant haematology, laboratory diagnostics for veterinary teams.
Good evening all, and thank you very much for coming to attend this webinar this evening with us. Lisa, thank you very much for the invitation, and it's a great pleasure to spend my evening with you. I will be talking about hematology and the diagnostics regarding the veterinary teams. My proposal will be to turn my camera off at this stage so we can concentrate on the slides and the presentation. And when we will start having some discussions about cases, and I will be showing you a little bit later some cases and ask for your opinion, then I can actually put my camera back on and have the interaction this way. So I will start straight away saying that a complete hematology assessment of our patient is basically made out of two components. The first one is the numerical data we get from the in-clinic hematology analyzers, and there are quite a lot of those available. And I will talk about those and the principles of methodology a little bit later. But it's a big plus with the numerical data. We need to also assess the morphology of the cells and generally the blood smear that we'll prepare from our patient. And it's extremely important to do both of these components to have a complete hematological picture. So what I would like to do in the next sort of hour or so, a little bit more than an hour and 10 minutes, we'll talk about the hematology analyzers and how we become the interrogators of the numbers, which are the principles that we need to remember every time we assess the sort of data that's generated by the hematology analyzers. Then we'll talk about the blood smear examination, and now on top of interrogators of numbers, we'll become detectives of the morphology of these cells that we look at and how this morphological assessment can help us to answer important clinical questions. I'll spend 2 or 3 minutes talking about the future of hematology assessment and how that is looking for the veterinary team in the clinic. And then we'll spend the remaining of the time going through some clinical cases with a slide of voting system. You will be able to scan a code with your mobile phone that will allow you to get into the slide, or you will be seeing the images that I will be presenting from the cases and have the ability to vote on the phone. If you are watching this webinar on your phone, probably it's going to be more difficult for you to do that. But if you're watching this webinar on your a computer, then you can actually scan with your phone the code that will come in a bit and be able to interact with us. Then we'll finish off with the main take-home points, and of course going to be the time for the questions. As Lisa said, these they can be written down. You can write them down on your on the chat, and then we'll go through and answer all these sort of questions. I'm more than happy to stay as long as it needs to answer these sort of questions. Now, with hematology analyzers, we need to remember that there are basically different types of hematology analyzers, and they work in different principles. The first one, and the oldest, and the first that was developed, is the ones that are based on the impedance or the electrical resistance. And this sort of hematology analyzers, in simple terms, they can count and identify cells based on their size. And the way that works this generally is that there is an electrode in the machine, and as the cells pass through and interrupt this sort of electrical current, if you want, this sort of interruptions, they are translated into aptitudes, and every time that there is a pulse, there is a cell. And if you have a big interruption, you have a big size cell. If you have a smaller interruption and a lower aptitude, we have a smaller type of cell. And this sort of hematology analyzers, they give you a full sort of hematological a set of results. So they will count the red blood cells. You can see here, they will measure the hemoglobin with a biochemical method, calculate all the other parameters, count the platelets, also will count the white cells, and then also attempt to actually give you a breakdown of different types of cells. Now, the key thing to remember is that these cells are recognized on the basis of the size. And it is sort of correct to actually say here that if you actually have some cells, and especially white type of cells, leukocytes, that are of similar size, then the machine will not be always be able to accurately detect the true identity of the sort of cells. And you can see here a normal neutrophil. Here we have a monocyte, and here there is a eosinophil. Some these cells, sometimes they can actually be of similar size, or measured as of similar size. And of course, the breakdown then based on the size is going to be not always accurate, because the cell, the machine cannot recognize a orange from an apple, and an apple from a pomegranate. Now, there is the later methodology analyzers that are based not only in impedance, but also in the laser flow cytometry. And these sort of analyzers, they not only can count and identify the cells based on their size, but most importantly, they can interrogate these sort of cells, and they can assess the internal structure, and they can see what is inside the cytoplasm, and they can assess also the structure of the cytoplasm in the presence of granules. So the way that they do that is that on top of the sort of aptitude and electric resistance and impedance methodology that can use for the size, also they have a source of a laser which is shot on the cells that are actually flow through, and then there are detectors based at different angles, and depending on the angle the detector is, can actually measure detect the scatter of this laser, and depending on the angle, they can actually get information about the volume of the cell, or they can also get information about the complexity of the cell as well. And this sort of analyzes, an example here is the ProCyte made by IDEX, which was one of the first that was developed based on this methodology, can give you again all the sort of similar results as the impedance. They can give you some extra information about the presence of immature red blood cells, that are the reticulocytes, which the impedance analyzers cannot provide. But because these sort of cells these analyzers can interrogate the internal structure of the cells, they can, with the laser methodology and the flow cytometry, they now they are able to more accurately identify the cells, especially the different types of white cells, not only based on their size, but now they can actually look inside and they can recognize and identify and separate the oranges from the apples and the apples from the pomegranates, because they can identify the structure inside the cells much more accurately. Therefore, the breakdown of the different types of white cells is much more accurate with this methodology. Now, when we look at published peer-reviewed evaluation studies in the veterinary world, and this is extremely important for us, always to go back to the studies when we want to find out about a new piece of instrument or new methodology that's in the market. We want to know what has been published, have been any validation or evaluation studies of these. There are quite a few about the hematology analyzers. Now, the way they're trying to actually present them to you is going to be more of a traffic light type of system. When you see the green, that will mean that the results are reliable in all clinically healthy animals and all ill animals, or almost all animals. Um, the orange is going to be again reliable in all healthy and most of the ill animals. And then on the red, we're going to have the situations where this sort of parameter of this particular instruments may be unreliable in a low number of healthy, but in many ill animals. And you can actually see just from the breakdown already that the more problems that we have is not so much with our clinically healthy animals, but of course with the animals that are unwell. So there are quite a lot of analyzers that have been published studies for them, and you can see them here. I mentioned ones that are available. And then when we actually look our traffic light system, you can actually see that red cell parameters, hematocrit, hemoglobin, total white cell counts, they are fairly accurate. But when we actually go into the breakdown of the white cells and the differentials, the different types of white cells, here we can actually see that we have a mixture of sort of some instruments that can reliable in all healthy and most ill animals, and generally these instruments, almost all of them, they are not particularly reliable in identifying eosinophil counts or monocyte counts in many ill animals. When we actually move into the impedance analyzers and the laser flow analyzers, you can see here that they are much less in number, because they are relatively new. There are more of them that are coming out, but these are the ones that we know that they are published evaluation peer review studies, and these are analyzers that I have here on the photograph. And when we look the traffic light system again with those, we can actually see that these analyzers, and we expect they do actually perform much better on giving us reliable differential white cell count. They are not perfect by no means, because they're going to be a percentage of ill animals where these analyzers, they will actually give us incorrect results. They will not be able to do the separation correctly. But you can actually see, comparing with the impedance, that the laser flow cytometer based analyzers that perform better on the white cell differential. It's interesting to point out that with the platelet counts, we do have generally a problem, irrespectively of the analyzer, especially with the ill animals. We tend to actually get incorrect counts from the analyzers that we have available, and this is where we need to start looking at the results from the hematology analyzers and the numerical data. We will get the hemoglobin, and the hemoglobin is measured with a biochemical method where the machines will sort of lyse the red blood cells, and they will be able to measure the hemoglobin from these cells that are lysed with the biochemical method. Then the hematocrit, it's a calculated value. We need to remember that is not a measurement per se. It's a calculated value which is calculated by the number of the red blood cells and the mean cell volume of the cell, the size, the average size of the red blood cells. Then, of course, we'll get the red blood cell count, and then we're going to have the parameters that they are associated with the red blood cells. The mean cell volume that will tell us about the average size of the red blood cells, the mean corpuscular hemoglobin concentration, and the mean cell hemoglobin concentration. Both of those parameters that will tell us about the hemoglobin concentration of the red blood cells, how red or how less red, more white the red blood cells look under the microscope, for example. Some analyzers, not the impedance, but the laser flow, they will give us a reticulocyte count. And then, of course, they will give us a platelet count, a total white cell count, and a breakdown of the white blood cell differentials, again, with a much less accuracy, specifically in the ill animals from the impedance, and higher accuracy with the laser flow cytometer based analyzers. It's extremely important to remember that we need to perform internal quality assessments on our instruments, on the hematology analyzers, and these they are standardized, and they are guidelines on the correct use of the point of care in clinic, in the veterinary clinic instrument, and we need to be looking at the different levels of the quality controls. The different levels of quality controls are these sort of made up tubes, which one will have normal results, another one will have low results, and the third one is going to have high results. And when people ask, how many of these quality controls will actually run? Do we need to run all of the levels? Uh, the correct answer will be yes. If the manufacturer is providing 3 levels, we need to do 3 levels to make sure that our instrument is set for the day and is able to identify and measure correctly all the different sort of like levels of results that we have from our patient. Now, of course, goes without saying, and say, look, these are expensive exercises. What is the minimum that they can actually do? The minimum is going to be 1 level of quality control out of the 3. And if we need to choose the normal to high or the low, then we'll actually go to run a normal mid-range type of quality control. The important question after that is how often shall we run the quality control? According to the guidelines, we should be actually run them daily. And I know that is something that does not happen in clinical practice. In real life, lots of clinics that don't actually obey with this rule, and that is a problem, because if we don't run quality controls daily, we cannot actually be assured that our instrument is going to be performing correctly and giving the correct results every single day. Now, we'll leave that for, I put that, oops, um, excuse me, that. If you are uh, having your phone, you can actually scan your this code on the Slido, and you will be able to um, see the results that I put here, and also the um, question. And the question is, when you look at this sort of result, which result do you think is analytically incorrect? And you can see here that we have a dog 7 years old. We run a in-clinic hematology analyzer, and we have the results here with the red blood cells, hematocrit, hemoglobin, MCH, MCHC, and so forth. And I just want you to look at the result and tell me if the machine was actually, if your instrument was actually giving you these results which of the ones that they are basically red, you think that's going to be analytically incorrect, that the machine is actually made a mistake. I know that the lots of you, when you're actually using an instrument, you will interrogate these sort of numbers very, very closely. And occasionally you may see some changes that you're not actually able to be absolutely certain if these are analytically correct or not. But in this particular case, I think that we are fairly sort of certain that there is something wrong with this instrument, because of course two parameters that we have that will tell us about the hemoglobin concentration basically are below the whatever detection limits this instrument has. Is that basically these numbers are very, very, very low. And I can actually see here, some of you have already um, voted, and you absolutely are correct. The incorrect result is the hemoglobin, and you can actually see here that the hemoglobin is 10 grams per liter, when obviously a low normal is going to be 131. And obviously that is impossible for the red blood cells to contain such a low um, um, such a low amount concentration of hemoglobin. So definitely that is wrong. And of course, because the MCH and the MCHC, as we said, they are calculated parameters, and one of the um, uh, parts that are involved in the calculation is the hemoglobin. Or if the hemoglobin is going to be extremely low, then these sort of parameters are going to be extremely low as well. So the key thing here is the hemoglobin is completely incorrect. There's something wrong with it, with this instrument that um, gave this sort of result, and obviously we cannot actually rely on that. The red blood cell count is reasonable, and the hematocrit potentially is um, it's okay as well. So based on that, we need to actually be aware of some little additional quality check that may be helpful. The first one is when you actually get results, and you can actually have a set of results here. One quick thing that you can actually do is to check that if you multiply the hemoglobin by 3, you should be getting, in the majority of cases, an hematocrit which is um, 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 which is correct, which is very close to the hematocrit from the machine, plus minus 3%. In this particular result we have from this cat, the hemoglobin is 10. The hematocrit came from the machine as 29.2. Then yes, 10 multiplied by 3 is about 30. So this is a pretty good result, and that's a very quick check to be absolutely certain that we don't have any sort of huge uh, deviations. Now, if the calculation of the hemoglobin multiplied by 3 does not give you close to hematocrit, then what you need to do is to actually spend a PCV, do a manual PCV, spin it down, and basically get that result as an indication of the cell red blood cell volume. The other thing you can do is to check the MCHC, which is calculated by hemoglobin divided by the hematocrit. And we need to know that the MCHC is a very constant um, um, in domestic animals. Obviously, it varies, the reference interval varies depending on the species, but most of our domestic animals, they're going to have MCHC that's going to be varying between 32 and 38 grams per deciliter. And the problem that we'll see with the MCHC in the majority of cases is that we'll have results that give us really high MCH. Now, high MCH, if we think about it, means that we have increased hemoglobin in our red blood cells. So we have hyperchromatic red blood cells. It's physiologically impossible to have red blood cells that carry more hemoglobin that they are genetically programmed to carry. So every time that we see a high MCH, that means that this result it's not physiologically possible, especially if the MCH is above 38. So that means that the hemoglobin is going to be falsely high. So this bit of the um, uh, division is going to be high. When we do get, the main reason for that is that somehow the machine, due to lipemia that increase the turbidity of the sample, or due to hemolysis with free hemoglobin, which is measured, increase this parameter. And now this hemoglobin that we have from the instrument is not only the hemoglobin that comes from the red blood cells, but also the free hemoglobin due to the hemolysis. So we need to actually check the sample and make sure that the sample is not lipemic and is not hemolyzed. The key thing to remember is that when we actually check this, make this sort of checks, and we'll see that we have a really high MCHC, which is not due to a lipemia of the sample or hemolysis, then of course we can rerun the sample. If we do get results again that they don't actually make sense, then we can repeat our QC. We can run the QC again to make sure that there is something that it was missed, especially if we don't run QCs every single day and we do them once a week or once every 3 or 4 days. It is extremely important to bear that in mind and run it again when we do have problems. And finally, if our QC again is okay, but we have still sort of like issues with the sample, then we need to actually be looking for technical support, especially if we start seeing that the QC start to drift and is not giving us the right sort of like answers. So the point that I want to make here is that it's extremely important for the team in the clinic to run quality controls with the hematology. And lastly, it is important to make sure that we select the correct species when we run our sample, because when we select the species, then obviously the instrument is going to give us an attached reference interval. And if we actually select the species as cats, and the actual sample is a dog, then obviously we will have results that will not actually make sense, because the results are going to come from the dog, but the reference intervals are going to be from the cat. And of course, we're going to have results outside the reference intervals all over the place. So it's extremely important just to remember that as well. So that will bring us to the second part of the hematology, which it is the blood smear examination, and we need to be aware that we need to become detectives and morphological sort of assessors. And the reason that we do that is, although, as I explained before, the hematology analyzers are extremely useful, especially the new generation analyzers with the laser flow cytometry. They actually have increased enormously the accuracy of the results, and we can still get quite in the majority of cases, reliable differentials and breakdowns of the different types of white cells. Even so, not all analyzers will provide reticulocyte counts. A reticulocyte count is quite important when we assess if anemia is regenerative or not, and I'll talk about that in a bit. At the moment, the only analyzer that can give us reticulocyte count from ones that have been evaluated is the ProCyte. All the other analyzers cannot. But another important thing is that the leukocyte differential count, although they are accurate in the majority of cases with the flow cytometers and the laser analyzers, they are not always accurate, specifically when you do have patients with inflammation or infection. Um, that inflammation, infection, and what that does to the cell morphology confuses the analyzers, and will still get results that actually are inaccurate, even from the laser flow instruments. The other thing is that in ill animals, we can have numerical hematology results that were within normal limits, but not always indicative of absence of clinical significant disease. And this clinical significant disease can be picked up only if we actually look at the blood smear and the morphology of the cells. Um, and follow on that is that the analyzers, they cannot assess the cell morphology. They cannot tell us what um, cell is um, all the times, especially if we have cells that they are atypical, cells that they are not the right morphological with the like morphological appearance. The analyzers, they cannot actually tell us about that cell morphology. The analyzers cannot detect parasites that they are present in the red blood cells or the white cells or the platelets. As I already alluded, they're going to give us wrong platelet counts, and they will falsely give us low platelet counts. And for this reason, it's always important for us to remember that we need to actually assess the blood smear, and it's an essential part of the hematological um, assessment of our patient. So with the blood smear, obviously, we will need to look at them with a microscope. We need to look at the blood smear that we'll prepare from the DTA sample. And we can actually go and do all the work in the monolayer. And the monolayer is the part of the film of the blood smear, where if we actually go with our 40 magnification lens at the feather edge, and then we backtrack about 3-4 fields, then they should be coming into the monolayer, where the cells are quite nicely spread. There are not many on top of the other, and we can look at them much more easily. It's extremely important if we want to become confident, if the member of the team that assess works in the lab and wants to become uh, confident in morphological assessment, we need to actually practice. We need to spend time looking at the blood smear, and we need to devote some proper attention, um, looking sitting on a comfortable area, and having a microscope which works well, and is clean, and is not make us put off because it's difficult to operate, or it's very dirty and we cannot actually see anything. And with a blood smear examination, the key thing that we do is that go into the blood smear when we want to ask specific questions and get clinically relevant answers. The first big one is when we have anemic patients, is the anemia regenerative? Then another important one is the anemia due to hemorrhage or hemolysis, a big category that we need to consider. Then, are there any red blood cell morphological abnormalities that will help us to determine the cause of the hemolysis if the animal is not anemic because of a hemorrhage. Then the other important question is, do I have any evidence of active overwhelming inflammation or infection? And it is important to remember, as I said before, that when we do have patients that have overwhelming intense inflammation, the machines are not always able to separate the different types of cells properly, and specifically they're not able to separate the neutrophils from the lymphocytes and from the monocytes. So when we have this sort of intense inflammations, the results that we get from the machines are not always accurate. Of course, the other important one, which the analyzers then we're not going to be able to tell us very clearly, is that do we have a neoplastic process present? Do we have a evidence of circulation in the circulation of neoplastic cells that indicate that we have, for example, leukemia? Again, as we said, the machine that will give us very commonly thrombocytopenia is the patient truly thrombocytopenic. And finally, um, do we have any parasites? Parasites can actually cause anemia. Parasites can actually infect white cells. They can infect even platelets. We have a whole set of vector-borne um, um, diseases that are more common and routinely sort of present in warm countries like my country in Greece and Italy and France, but we see them in the UK as well, especially the animals that actually coming back from traveling and so forth. So it's important to be aware of these parasites. So let's start with the anemia, if it is regenerative or not. So if we have a machine, we have an instrument that give us a reticulocyte count which is accurate, and at the moment the ProCyte, it has give us a reticulocyte count which studies have shown that is fairly reliable. It's fine. But if we don't have a hematology analyzer, how will we actually answer this question? Is the anemia regenerative or non-regenerative? And it's important to remember that we need to answer this question because depending on if the anemia is regenerative or not, we have different sets of diseases and of course pathomechanisms. So with the regenerative anemias, we're going to have the hemorrhage and the hemolysis, and of course with hemorrhage we have internal, external hemolysis, and then we have hemorrhage, and then we have hemolysis, which can be an immune-mediated type of hemolysis or hemolysis due to other sort of like mechanisms. And of course, if the anemia is non-regenerative, we're talking about completely different set of diseases. We're talking about primary intra-bone marrow badness, where the marrow is not actually working properly, and that's the result of the, and that's the reason for the anemia. Or we have some systemic disorders, diseases that affect the erythropoiesis and the production of red blood cells in the marrow. As an example of the primary intramarrow disorder will be, for example, an aplastic anemia or a neoplastic process where, the marrow has lost all the sort of part of the of it that is responsible for the production of erythrocytes. And a systemic extramarrow disorder will be a chronic renal failure where the kidneys are not producing erythropoietin, and erythropoietin is extremely important for the synthesis of hemoglobin and red blood cells, and therefore we start getting anemias that are non-regenerative. Um, so when we actually have a regenerative anemia, looking at the blood smear, the first thing that we'll see is anisocytosis, red blood cells of different cell sizes. Then we have polychromasia, the presence of polychromatophils, which are the same cells as reticulocytes, as I explained in a bit. And then we may have or not the presence of nucleated red blood cells. And you can actually see here that basically the essence of regeneration is that we see immature red blood cells in the circulation. And these mature red blood cells are the polychromatophils and also the nucleated red blood cells. And these immature cells, they are in the circulation because there is an intense demand from oxygen, and the marrow does not allow the red cells to mature in the marrow all the way, and instead they start changing the architecture and sending out immature red blood cells, because these sort of cells, immature, they will be able to carry some hemoglobin and to mature in the circulation and carry some hemoglobin and deliver oxygen into the tissues. So anisocytosis is the presence of cells of different sizes, and generally big cells, bigger cells are immature cells, and then obviously the more mature cells are smaller. As you can see here, the different sizes. Then we have the polychromatophils. The polychromatophils are these larger blue sort of cells that don't have enough hemoglobin inside them. They can carry a little bit of um, uh, oxygen when they mature. And this sort of polychromatophils, they stain blue with a diffquick stain, but when we stain them in a different way, these are the reticulocytes. These are exactly the same cells, but they are called different names because they are stained with different stains, but they are sort of like immature red blood cells. And then we have the presence of the nucleated red blood cells. As you can see here, these are the nucleated red blood cells. They are the young cells. These are the cells that they are much younger than the polychromatophils. And these sort of cells, they will come into the circulation when there is excessive demand, when there is so much demand for oxygen, very severe anemia as well, where it's not only the polychromatophils that are needed, but also now earlier younger cells need to come to the circulation. So that indicate um, excessive demand for oxygen. So when we do have this sort of results, we have a regenerative uh, this morphological type of erythrocytes will have regeneration. Now, if anisocytosis, polychromasia, presence of nucleated blood cells are not present, that means that the anemia is a non-regenerative anemia. And you can see here that the cells basically are normocytic and normochromic, meaning that they are the normal size and the normal sort of like color. And this is something that we'll see on our numerical data from the instrument, where the MCV that tell us about size, there's going to be normal, and the MCH and MCHC that the parameters tell us about the hemoglobin, they're going to be within reference intervals as well. And as I said, if we do have this type of anemia, then we have different disorders that we're talking about. So that is the first question. The second question is, okay, we decided if the anemia is regenerative or non-regenerative, and we found that the anemia is, let's say, regenerative. Is this sort of anemia due to hemorrhage, or is due to hemolysis? And of course, the differential features between hemolysis and hemorrhage, they will come a lot from clinical history. Animals that have trauma, animals that have surgery, animals that have history that can fit with hemorrhage can help us. The biochemical analysis can help us a bit. Generally, with hemolysis, the total proteins, the albumin, are within reference interval, or if we have some dehydration, we may actually be increased from that respect. And the total bilirubin can be normal with hemolysis, or if we do have hemolysis quite intense, of course, we can actually have increased bilirubin, because obviously the hemoglobin, which is coming from the hemolyzed red blood cells, is converted into bilirubin. Now with hemorrhage, in the majority of cases with this hemorrhage, we're gonna have total proteins and albumin very often that's gonna be low, and of course the bilirubin will actually be normal. But when we look at the blood smears, we can actually have regenerative anemias and in both conditions. So one thing that I will actually say is that when we do have chronic external hemorrhage, we have a loss of blood externally, most commonly via the gastrointestinal tract. Then we lose externally red blood cells, we lose hemoglobin, and of course we lose iron as well, which is inside the hemoglobin. And when we have this sort of chronic loss of hemoglobin and iron, then the animals become animal depleted. And of course, iron is extremely important for the synthesis of hemoglobin in the marrow. And as a result of that, then the marrow is not able to produce any red blood cells, and as a result of that, eventually these sort of chronic hemorrhages they become non-regenerative. And also these sort of cells, very commonly the red blood cells are smaller and also they are whiter, so they are microcytic and hypochromic. As a result of this lack of iron, the red blood cells go to an extra division and they become smaller, and then as the iron becomes to not be available, they become whiter as well. So that is an indication of a chronic external hemorrhage. If the hemorrhage is internal, we don't get that because the hemoglobin and the iron in the hemoglobin, they are basically reabsorbed and are used again in the marrow for the synthesis of hemoglobin. So in this particular case, let's do a look at the case. We have Kelly, which presented with progressive weakness, exercise intolerance, and lethargy and anorexia. You can actually see here that Keely is anemic, hemoglobin is decreased, hematocrit and red blood cells as well. When we actually do our checks, we can see that hemoglobin is around 19, so it's very close to the hematocrit. But here also we can actually see that the MCV is low, so we have macrocytosis. And when we pair this sort of evidence with the blood smear, you can actually see this sort of smaller cells, red blood cells. So this is, for example, the right size for the red blood cells. So you can see here that there are quite a few that are actually much smaller. Now, someone will actually say, okay, fine, but what about if I didn't have a hematology? I mean, how will actually numerical data, how I will be able to say that these are small? One thing you can actually do is basically you can compare the size of the red blood cells that you are questioning that are the right size with the size of the neutrophil. And in the dog, a normal size red blood cell should actually fit about one time, 1.5 times in a neutrophil, and in a cat, two normal size red blood cells will fit in a neutrophil. And immediately in this particular dog, you can appreciate that, for example, this here can fit at least 3 times. These small ones, they can fit at least 2.5 times. So indeed, these are the small red blood cells that are reflected with a decreased MCV. And then also we see that the MCH and the MCHC are decreased. That means that our cells are whiter. And again, we have hypochromasia. And these are the hypochromatic cells. You can see how much whiter the red blood cells look. So if this here, it's a normal color for red blood cells, you can see that all these with a much whiter are the red blood cells, the hypochromic cells. In this particular case, Keely, it was bleeding externally. It had a gastrointestinal bleed, and we found a carcinoma in the intestinal tract. We've done ultrasound and found sort of like the presence of a mass. So it was actually bleeding chronically through the gut, and that's why it was microcytic and hypochromic. And you can actually see here that the picture is reflected on the blood smear. Okay, the other question is that if the animal has regenerative anemia and is not hemorrhaging, therefore we have hemolysis, do have any red blood cell abnormalities that will actually fit with the cause, would help us in the cause of the hemolysis. And when we start looking at those, if we want to become good at picking those sort of causes, we need to be able to identify the presence of agglutination, spherocytes, and ghost cells, because if we're able to identify those, then we can actually say that this anemia, hemolytic anemia, is an immune-mediated hemolytic anemia. Then the other thing that we should be able to train ourselves and identify the presence of eccentrocytes and Heinz bodies, because if we are able to identify those, that means that we have a oxidative damage of the red blood cells, which basically this oxidation of the red blood cells create red blood cells that are vulnerable and they can actually lyse easily, and that's why we have hemolysis. And you can see here that there are quite a lot of conditions and diseases that can give us the presence of oxidation and the presence of eccentrocytes and Heinz bodies. Garlic, ingestion, onions, we know commonly do that. Anticoagulant or densite toxicity can give us oxidation. Diabetes mellitus, systemic diseases, T-cell lymphoma, diabetes mellitus, hepatic lipidosis. These can actually create oxidation and potentially hemolysis. And finally, another mechanism that can give us hemolysis is due to mechanical damage of the erythrocytes, and this is present to us the blood smear with the presence of acanthocytes and schistocytes. And the big player in this cause of hemolysis is hemangiosarcoma, specifically hemangiosarcoma of the spleen, that can give us this presence of acanthocytes and histocytes. Of course, when the hemangiosarcoma ruptures and we have hemorrhage, then it's hemorrhagic disease, but the presence of acanthocytes and histocytes can be in the circulation before, much before we have any rupture of the tumor of the spleen. And of course, there are other diseases that can give us acanthocytes and schistocytes. So this is the red blood cell agglutination. These are the three-dimensional clustering of the red blood cells that have antibodies on the top of them that are actually get cross-linked. And we need to distinguish this sort of bunch of grapes, if you want, from this sort of rouleau, the stack of coins that is created very commonly in our species because of the electrical charges that are on the red blood cells. So these are the two different conditions. This is a rouleau, this is agglutination. Then we have the presence of spherocytes, and these are the sort of very spherical, darker cells, red blood cells, that they are formed when we have the macrophages removing part of the cell membrane that has the antibody on it, and that membrane loss leads to a much more spherical shape. These are difficult to recognize in cats because the normal feline erythrocytes are very similar to those. They don't have a very intense white pallor that we have in the dogs. We make it much more easy to see them and compare them and pick them up. And the ghost cells, they are actually empty red blood cells that they are present specifically when we have intravascular hemolysis, and we have this sort of like emptying, if you want, of the hemoglobin into the circulation. And these are the sort of very fainty cells in the background, extremely useful for picking up immune-mediated process. And here in this picture here also you can see we have lots of spherocytes. And of course, this anemia, it is a regenerative one because we have polychromatophils, these big blue cells, and we have also the nucleated reds as well. Now, with the hemolysis due to the oxidation, we have the excentrocytes that they are and the Haynes bodies, and this is what they look like. The excentrocytes are this sort of red blood cells that they have this sort of white area, and this is because the hemoglobin is being pushed further in, and that's because the cell membrane has been damaged, has been oxidized. From the cause which is behind this oxidation, so it creates sort of a white bit of the red blood cells. So these are the excentrocytes, and then we have these sort of little darker bodies that they are inside sort of red blood cells. You can see them here. These are darker bodies, are the Haynes bodies that now are basically bits of oxidized hemoglobins that has been sort of get together and create um, um, this formation. Sometimes you can actually see them poking out little pink noses from the red blood cells here and here and here. But quite often you can actually see them together with the excentrocytes as well. So this is the picture that will tell us that we have an anemic animal due to hemolysis from oxidation in this particular patient. And finally, with the mechanical damage, the acanthocytes are these sort of spiky cells. These are the cells that are pointed by the black arrow here. They have these sort of spikes. They are irregularly placed around the red blood cells, and they have this sort of more pointy or sort of more curvy, if you want, appearance. Um, and this is how these sort of cells are getting damaged as you go through the vasculature. And specifically with the hemangiosarcoma in the spleen, you can imagine the hemangiosarcoma as a tumor, as razors in essence. And as the cells go through, they're getting really chopped off and damaged from these neoplastic sort of cells that are in the spleen. And an excessive mechanically damaged red blood cell would be a schistocyte, which in essence is just a bit of a red blood cell. It's not a whole red cell anymore. It's just a bit of it. So these are the acanthocytes and the schistocytes. So when we getting trained from the blood cell morphology side, this is the findings and the morphological abnormalities that we need to get familiar and be able to identify confidently. Now, moving to the other question that is important is there evidence of active overwhelming in inflammation? And someone will actually say yes, that but we can actually get that answer from the numerical data, isn't it? Because if we have neutrophilia, we know that we have inflammation, which is true, but we will actually have quite a lot of cases with inflammatory processes going on active, quite important and overwhelming sometimes, or inflammatory process, and the numerical data can be normal. So when we're actually looking for these indications morphologically, is we're now looking at the neutrophils, and we want to be able to pick up mature neutrophils and toxic neutrophils, because these, they're going to tell us that we have an active inflammatory process. And when we have the presence of mature neutrophils, we have a neutrophilia with a left shift. And we have increased inflammatory demand for neutrophils. The neutrophils that are available in the storage have been depleted, and now we come, the bone marrow needs to let out immature neutrophils that they will be there to try and fight the infection or deal with the inflammation. These neutrophilia with left shift is less common in the cat, just because cats, they have much more reserves of mature neutrophils in their storage pools, and therefore they don't throw this sort of left shift as commonly. Now, why we call it a left shift? We call it a left shift because someone decided that the neutrophils, they're actually mature, the cells mature from the left to the right. So when we actually have the presence of lots of immature cells, which are the metamyelocytes, here you can see them, and the bands, then we have a shift to the left. And you can see them here. This is a band neutrophil in comparison to the mature neutrophil. And generally, when we look at the blood smear, if we start seeing more than one immature neutrophil per 10 fields with our times 40 lens, that is a significant, that indicates that we have a significant, clinically significant left shift and presence of inflammation. Now, toxic neutrophils. What are the toxic neutrophils? Before we start recognizing the toxic neutrophils, just to remind what a normal neutrophil looks like, we have a very nice, intense blue lobulated nucleus and a quite nice, sort of smooth cytoplasm. Now, what are the toxic neutrophils? The toxic neutrophils are they're developing in the marrow, and they are morphologically abnormal. And they are morphologically abnormal because there is a shortening of the maturation time. So the neutrophils, instead of actually taking the proper time to mature, they're actually rushed for the to mature. And because they are rushed, they are actually morphologically not right. And the reason that they are rushed is because there is an overwhelming inflammatory response and or infection potentially, and the marrow needs to send out neutrophils as soon as possible. As a result of that, does not let the neutrophils to mature properly. And because when we rush, we make mistakes, the marrow makes mistakes and produces these toxic neutrophils. These toxic neutrophils, they are having characteristic changes on the cytoplasm, which is basically more basophilic, more blue, and has a bit of a foaminess. And you can see it here. This is a band neutrophil, which is toxic because it doesn't have a very nice, smooth cytoplasm. It's much more blue, and it is more so foamy, little vacuolated, you can see here. And the other thing that the toxic neutrophils can have is they can have some other bodies that are called dolly bodies, that they are these sort of blue irregular aggregates of endoplasmic reticulum. Again, these, they shouldn't be there, but because the maturation is not proper, we have these sort of spots inside the neutrophils, these blue spots there. And again, that is a toxic neutrophil and a mature neutrophil with a blue cytoplasm and these dolly bodies. And you can see some more here. These are all toxic neutrophils, and you can see the foaminess and the blueness. And here you can see the sort of more paley dolly bodies as well. Now, why it is important for us to identify the toxic neutrophils, and why and the toxic neutrophils cannot be identified by their instruments or analyzers. In the dogs, we will see them commonly in quite severe sort of inflammatory infectious conditions. You can see here lots of these, but also you'll agree with me that there are conditions that are not infectious, like an immune-mediated hemolytic anemia or neoplasia, that will actually see toxic neutrophils as well. So intense inflammatory response will give you those. And it's impossible to pick those up, because if we see toxic neutrophils in the dog, that means that we have a longer hospitalization period, and of course we're going to have a higher treatment cost. But importantly, there is a higher case fatality, meaning that the dogs with toxic neutrophils, more of them, they will not actually make it for whatever reason, either from the disease process, or they're going to be too unwell and not responsive to their treatment, where there's going to be decision from the owner to call it a day. But these dogs are going to have, we're going to lose more of those dogs with toxic neutrophils. Now, in cats, it's interesting that about 50% of cats with toxic neutrophils, they have normal white blood cell counts and neutrophil counts, half of them, but they have toxic neutrophils. And again, we can actually see them in quite similar, um, quite intense infectious or inflammatory conditions, or conditions that will will create this sort of inflammatory environment. And in cats, in the similar way with the dogs who have long hospitalization, higher treatment cost, but in the cat we don't have a higher case fatality. There is not difference between conditions that have toxic neutrophils or not in cats. So cats have 9 lives, they will actually be able to actually make it even with toxic neutrophils. And these are some more toxic neutrophils you can see here, the dolly bodies, and there is one that has a donut shape, and this is really indication of marked toxicity. Now, one thing that I will say here is that the ProCyte, I'm talking about the ProCyte because there are studies published for this analyzer, whether it's not for the others, laser flow cytometer on this aspect. And the ProCyte can give you an accurate leukocyte analysis. And about 10% of cats, samples of cats, only half of them, they will actually generate a flag. So the machine will actually say, look, I cannot actually give you an accurate white cell breakdown. You need to look at the blood smear. In 10% of samples with inaccurate leukocyte analysis, only half of them, the machine will actually flag them. The other half is going to come out as normal, properly, sort of results with no flags. And in these 10%, basically the machine will have falsely give you increased lymphocyte count and falsely decreased neutrophil count. So this is where you see the combination where you have a really increased lymphocyte count and a low neutrophil count. If you see that in a sick animal, in a cat, then you start to actually think that that might not be correct, and you need to actually check your blood smear. Similarly, in the 15% of samples in dogs, in these situations, all of them are going to be flagged by the machine, and will tell you, look, I haven't actually done a good job, falsely increased lymphocyte counts and monocyte counts, and falsely decreased neutrophils. You will actually see that pattern happening in the dog. So in this situation, you need to actually go to blood smear. And in these cases, has been shown that this sort of incorrect separations of white cells and incorrect leukocyte result are because there is a left shift toxic neutrophils present in the blood smear. So it's the most common reason for the white blood cell differential counts inaccurate from the ProCyte, and that's why the blood smear examination is important. Now, moving away from the inflammation, is the neoplastic process present? We should be able to see if there are any atypical cells, any unclassified, weird-looking cells, any blast cells that they shouldn't be there in the circulation. So, as an example of those, these are cells that they are quite big. They are not normal lymphocytes. They have a funny shape, straight shape, nucleus. Um, and when we see these sort of atypical cells that indicate malignant neoplastic process, the type and the lineage is not always apparent. And this is where um, when we have an emergency case, an animal which is quite sick, is anemic, we see the blood smear, we see the sort of cases, it's important for us to be able to pick them up and proceed. And this is where it's important to be able to us to identify them if we cannot, to take photographs and contact the lab or scan our smear and send it to the lab and ask for opinion of the clinical pathologist, so we can actually move on with the diagnostic work. The blast cells, we should be able to pick them up easier because these are the cells that are quite big, and they have one prominent nucleolus inside the nucleus, or sometimes they may have more than one nucleoli, as you can see here. In this, there are at least three, and maybe another nucleolus, there are four. So these are blast cells. They shouldn't be there. We shouldn't be actually allowed to see even one of them. When we see them, are abnormal. They shouldn't be there. They have quite a blue, often quite a blue cytoplasm as well. And that indicate that we have a neoplastic process. We need to be able to identify them and see if they are from what lineage they are, because that can have an effect on the treatment. Um, and of course, they indicate that we have a neoplasia. If these are coming from the bone marrow, then we have a leukemia. If these sort of cells they're coming from some other organs that are actually have a neoplasia, they can actually spill over in circulation. Not as commonly, but can happen as well. And then the other question is that we have with our analyzers, that is the patient truly thrombocytopenic? The importance of thrombocytopenia is it is more intense when we have an emergency patient, a patient that we doing hematology in out of hours on a Friday night, and we get this sort of numerical data from an analyzer, it's a thrombocytopenic. The majority of the analyzers will give you a false thrombocytopenia because the platelets are clumped in the sample and the machines do not count them properly. And you can see these sort of clumps in our smear. Or they may actually have large platelets, these sort of micro platelets, which are as big as a red blood cell, and the machine will count them as a red blood cell. So we're going to get incorrect platelet counts. So how do we do that? So we estimate the platelet count from our blood smear. So we make our blood smear and we stain it. First of all, we go at the further edge, which is here on our times 20 lens, and we're trying to see if we have platelet clumps. If we see platelet clumps, then it is highly likely, almost definite, that the count is incorrectly low. This patient is not thrombocytopenic, and if there are enough platelets to clump in the blood smear, there are going to be enough platelets to clump inside the patient, so we're not going to have any problems with the platelets. If we do not see any platelet clumps in the further edge, then we're going to go and examine the monolayer. So with the monolayer, as I said, we are in the further edge. We'll move 3, 4 times 40 fields backwards, and then we'll gain the monolayer. And what we're going to do there, we're going to put some oil, get an oil lens, and we're going to start count platelets in 10, 20 fields. And when we are finished with that, we'll calculate the mean number. And if it is a cat, we'll multiply by 20, and that will give us the platelet count. And if there is a dog, multiply by 15, and that will give us the platelet count of the dog. So with this methodology, we can actually have a pretty good assessment of the platelet count and answer the question if our patient is truly thrombocytopenic or not. And finally, do we have any parasites present? We can actually see some parasites like this one. This is a Dirofilaria. It's not always present. Sometimes we'll see it. Most of the times we'll not, but occasionally we'll see it. And that's another reason to look at the blood smear. Of course, red blood cell parasites. Here we have Babesio's. You can see them intracellular parasites. They have sort of pear-shaped appearance, and you can see them here in lots of red blood cells, intracellular parasites. The machine, the instrument is going to pick those up. And of course, as I mentioned, although rarely seen on a blood smear, we have sort of wonderful parasites of the white cells that are associated with more with vector-borne diseases like Ehrlichia and Anaplasma, Hepatozoon. These are all in the hot countries, as I mentioned before. Just to give you some examples, this is a monocyte that has a Ehrlichia morula. You can see this sort of structure here. These are just normal neutrophils. This is another parasite which is an hepatozoon. Gammon inside the neutrophil looks like an antibiotic pill, but is easy to pick them up. None of those that will be picked up by the instrument. And here inside the platelets, we have sort of morula of anaplasma morula that you can actually see those here. And these are parasites of the platelets. Those they're not going to be picked up by an instrument either. This neutrophil, that's a monocyte for completion. And you can see the platelets that are not, they do not have parasites here. So that's what I wanted to actually say about us being interrogators and morphological detectives. Now, what is the future? Um, there are some new point of care hematology analyzers that are made in, they are presented and they are run in human medicine, which are actually based on heavily on artificial intelligence as well, but also they are simplified and they are run by a drop of blood into a cassette, into the instrument, and off you go. You have all your results ready from those. And notification of the results based the artificial intelligence assisted type of diagnosis. And one of those that is been available in human medicine. This all is there are studies published as well. There's another one which is the Pixel that came out. Hemoscreen is is called the instrument. It's very similar to the Olo. The only difference is that you have a different type of cassette that goes in, and these all sort of parameters are calculated automatically. And the attraction here is that also you require only one drop of blood. There is no blood smear necessity, and there's not tubes or anything. It's just a little cassette, and there is a paper that published on that. And finally, there is sort of HELAB machine, which is a very similar type of analyzer. Again, you have the blood that goes into another type of cassette that goes in, and then the machine does all the analysis, identify morphological results and everything. And again, is highly rely on artificial intelligence. These are designed for point of care facilities in next to humans, next to the patient type of results, and have been tried in lots of established and pediatric hospitals, oncology units, and so forth. And when I looked for published studies, peer-reviewed, looking the evaluation and the clinical application of those analyzers, artificial intelligence, are found at least 8 on the last published, the last sort of like 8 years. Most of them that came out after 2020. Now, there are some new point of care hematology analyzers in veterinary medicine, and I'm sure you're aware there is the InView analyzer from IDEX, and there is a OptiCell that is from Zoetis, that you can actually see that they have a very similar sort of feel, and the methodology and the whole concept is very similar to the previous analyzer that I showed you about humans. And indeed, the methodology is very similar, and also they are trained, and they're using artificial intelligence for morphological assessment and identification of cells. Now, when I looked to see any published evaluation studies, peer-reviewed, there were none. So there are not any studies published for these analyzers. Now, we can look at our cases. We're running a little bit late, but as long as you are happy to stay with me for the next sort of like 10, 15 minutes to look at our cases, I'm more than happy to do that, and I hope that you will. I'll put my camera on just to make it a little bit more sort of um, interactive, if you want. And I will start the first case. You can see the results here from a Trent, which is a 3-year-old male beagle dog. And also I'll give you the blood smear image. It's a representative image from this patient. And you can actually see the results here. I'm not going to go into the breakdown of the white cells at this point. So Trent is anemic, and I want you to answer the question, do you think that this anemia is regenerative or non-regenerative? The hemoglobin is 8, hematocrit 26. You can actually see the blood smear representative of our patient. What do you think? Is the anemia regenerative or non-regenerative based on our red cell morphology? Trent also had a decrease um, white cell count as well, but let's concentrate on the anemia. Okay, I have some answers. Most of us are saying non-regenerative, and yes, you can do more if you want. Um, but I would agree. This is a non-regenerative anemia because first of all, I can actually see that most of the red blood cells are very similar in size, but most importantly, what the other thing that we want to see is the presence of polychromatophils. Polychromatophils are the reticulocytes. These are the bigger blue cells. We don't have any bigger blue cells here. They are all the cells. They are very much of the similar color and very similar in um, size. So this indeed is a non-regenerative anemia. Now, looking at our results and moving now to the white cells, we have here an increased white cell count. And um, looking at our white cells, indeed, the majority of the cells, the vast majority of the cells are small lymphocytes, which you can actually see here. That's not a lymphocyte. Maybe that's a neutrophil with a sort of scrumped up sort of like nucleus. But these are the lymphocytes. So we have a quite marked lymphocytosis. And from that, when we have this sort of increase, we're talking about a lymphoid leukemia as the reason for that. Now, is it possible that this lymphocytosis, it is a reactive lymphocytosis, meaning that we have an immune stimulation, and that's why the lymphocyte count is so increased? At this sort of level, it's going to be impossible. Most of the lymphocyte counts that are going to be related to an immune stimulation reaction will actually be probably um, up to 3 times normal, something like that. After that, we have the problem with neoplastic process with leukemia. In this particular case, we went further and we ran a flow cytometry where we looked for markers on these red blood lymphocytes to see what sort of type of these sort of cells were, um, um, and if there were one specific type of cell which will fit with the leukemia. Because when you have antigenic stimulation and you have a mixture of different cells, lymphocytes, where in this particular case you can see that we have the markers for the T cells positive in 97% of the of the sort of cells which actually will fit with the T cell leukemia. Now, flow cytometry, it is not straightforward thing to do. We need to get the sample, the blood sample, into a container that has a specific liquid, and then we need to actually send it to the lab for that analysis to take place. But that's an example of lymphoid leukemia, and the anemia, the non-regenerative anemia, it is part of this leukemia. Obviously, the marrow is going to have lots and lots and lots of lymphocytes inside it and less space for the erythrocytes to produce. Now let's look at Holly, who is a 7-year-old mixed breed dog, presented with progressive weakness and exercise intolerance, and on the clinic in the clinic was lethargic, anorectic, tachycardic, and had pale mucous membranes. So these are the numerical data from Holly. And this is the blood smear image. We can actually, this is a representative of Holly's blood smear. You can actually see the results here and the parameters that we were talking about before. The MCV is increased. The MCH and the MCHC are both massively increased, and we have a leukocytosis. As we said, remember that we said before, we said that it is impossible really to have hyperchromic red blood cells. So every time that we see really high MCH and MCHC, we need to be looking for the um, um, cause, and the most common cause is going to be hemolysis or lipemia. And these is our blood smear. And what I want you to ask you is that Holly, is the anemia regenerative or non-regenerative based on the blood smear? We can actually see how spread the red blood cells are, which will fit with the severe big spaces in between with the anemia. Well, and there is a leukocytosis here as well, and indeed we can actually see that we have quite a lot of white cells as well in the background. Let's see. Yep, regenerative. Most of us say regenerative. Indeed, this is a regenerative anemia. And the reason that we have regenerative anemia is because we have the presence of loads of blue big cells, which are the polychromatophils. And on top of that, we also have these nucleated red blood cells you can actually see here in the background. You can see them here, polychromatophils and nucleated red blood cells around. So the next question will be, are there any morphological abnormalities that helping to determine the cause of the hemolysis? Apologies for the spelling mistake. And when we look for clues for the hemolysis, do we have any spherocytes? Do we have, which will fit with an immune-mediated? Do we have eccentrocytes that will fit with the oxidative cause of hemolysis? Or do we have acanthocytes which will actually fit with more of the, as we said, the damage, mechanical damage, macroangiopathic sort of cause for the hemolysis, non-immune? Thing is with you that you're looking at your sort of, you have scanned the photograph, you can actually zoom in your phone and increase the um, sort of the size of the image. I will have the image bigger in a bit, so you can examine your findings, your cells. It's very obvious, obviously, the regenerative sort of form of the anemia. Let's see, what sort of cells have you identified? Okay, let's look. The cells that I can see are the spherocytes, and the spherocytes are the sort of darker round. There are lots of them. This is a spherocyte as well. Spherocyte, 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 spherocyte. The ones that they're easier to pick up because the ones that they have this sort of white bit in it, obviously they are not. So all the other cells that this is a spherocyte as well, spherocyte also. So there are quite a lot of spherocytes. Now, why we don't have eccentrocytes? The eccentrocytes, if you remember, there were these sort of cells that they had a white area inside them, right? Red blood cells that had pushed the hemoglobin, and there was a white little hat on top of which we don't have here. But what we do have, that's the spherocytes as well, loads, as I mentioned. We have ghost cells. There they are. For you that potentially you are quite keen, or you are very sort of pay close attention, there are quite a lot of ghost cells. These sort of cells are the ones that we mentioned before, that they are actually empty the hemoglobin, and now the whole thing makes sense. Is that, remember that we said that the MCHC and the MCH, they were actually increased. There were more hemoglobin measured, more hemoglobin in the sample, and there was a mismatch between the hematocrit and the hemoglobin, and that was because there was a free hemoglobin from the hemolysis that was measured in the instrument, and this was coming from these ghost cells. So our diagnosis here is immune-mediated hemolytic anemia. There's another one, more straightforward question here. We have an anemic dog. It's a blood smear. um, the cells that are pointed with the blood with a black arrow are what? Are they polychromatophils? Are they hypochromic erythrocytes? Are they acanthocytes, or they are spherocytes? We can actually we can see that there is a anisocytosis. There is a difference on the size of the cells. We have some smaller cells and some bigger cells, and there are some smaller cells here. Um, and then we have these cells here. These are the platelets in between, the little structures here, that are the platelets, and we have a one neutrophil here on the top. Okay, let's see. Yes, absolutely. We do have polychromatophils. You're absolutely right, but not these are not the ones that we point out. The ones that we point out with the arrows are this darker, more solid, if you want, spherical, which are the spherocytes. This is a polychromatophil here. This is a polychromatophil here as well. And there are some bigger ones. There are two polychromatophils here. This is probably polychromatophil. That's a polychromatophil, a much bluer cell. So, and there is another one here, and there's another one here as well. So this is again a regenerative anemia with spherocytes and immune-mediated hemolytic anemia. What about this one? Another anemic dog, and what are the pointed the cells that are pointed by the arrows? What are they? Are they spherocytes, acanthocytes, excentrocytes, or blasts? These cells in the background, there are platelets. Here you can see them, that they are in little sort of loose um, aggregates. And this animal has, or the blood smear from this animal shows that there is quite a few gaps in between the red blood cells. So probably we do have an anemia in this animal also. But what are these um, cells? Absolutely, you are all correct. There are acanthocytes, those spiky cells that indicate that we have a mechanical damage of the cell membrane, and these cells are become quite fragile, and they can be recognized by the macrophages in the spleen as abnormal. They can be attacked, but become quite fragile. They can actually lyse, and therefore we can have the hemolysis. Now, is this anemia regenerative or non-regenerative? Is a non-regenerative anemia because we don't have any polychromatophils. We don't have any big blue cells. Most of the cells are very similar in size, taking into consideration the different shapes, but most importantly, they are the same color. So they are normochromic. What about this case here? This is Rue, 10 years old, a border collie. These are the results that I'm giving you with hemoglobin, hematocrit parameters, and a impressive white blood cell count of 142, almost 9 times, 8 times normal. Um, this is the um, blood smear from this patient. And I want you to tell me what are these sort of cells that we point with the red arrows? What are they? Are they normal mature neutrophils? Are they normal but immature neutrophils? Or do we think that they are toxic mature neutrophils or toxic immature neutrophils? There you are. A combination, play with words here. What do you think these are? Um, And I think that it's very sort of obvious. I would say that out of all these 142, then the 9 white cells, the majority, I would say, going to be made out of neutrophils. And let's see what we think. Correct into, I'm happy that all of you identify those as immature ones. In matter of fact, these are the sort of like banned neutrophils, absolutely immature. And they are toxic because they do have a more sort of more foamy and a little bit more bluey gray type of appearance. So they will be toxic. And this one here, I hope not with too much imagination, you would agree with me that it is a dolly body here, this sort of dark little blue. So these are indeed toxic immature neutrophils who have a massive neutrophilia with a left shift and toxic neutrophils. The animal is anemic. This anemia is a non-regenerative anemia because we have only one really polychromatophil here, and the rest of the cells are not giving us any indication for regeneration. These structures here, this formation of the red blood cells, it's the classic rouleau that we were talking about. They are not agglutination. So we have a non-regenerative anemia due to a massive sort of inflammatory disease. And this particular case, Rue had a prostatic abscess with this really intense inflammation. And with this, I will leave you with a take-home point. Talking about the in-clinic hematology analyzers, they are extremely useful, as we said. The internal QC is extremely important and necessary. I cannot stress that to you more than I could. It's extremely important. We need to actually do those. The impedance and the laser flow combined analyzers, the newer ones, are better than the impedance ones, but they do not provide complete hematological assessment. Not all analyzers will give you reticulocyte counts. The leukocyte differentials, as we demonstrated with the studies that we have based on the ProCyte, they're not going to be always accurate, specifically when we have intense inflammation, infection, toxic neutrophils will throw us incorrect results. The numerical results can be within normal limits and not always giving you the indication that there is clinical disease, and that's why we need to go for the blood smear. Of course, the hematology analyzers do not assess the cell morphology. They're not going to tell you if you have spherocytes. They're not going to tell you have eccentrocytes, acanthocytes. They're not going to tell you if you have blasts or weird type of cells or parasites and organisms. The prone to falsely low platelet counts, as I demonstrated before, and that's why it's important to check that thrombocytopenia is correct, it's true or not. And for this reason, we go for the blood smear examination always, because it's quite important for us to be able to answer the sort of questions which are not cannot be answered by just the numerical data. And these are the questions that we went through, with the anemia being regenerative. You have any hemorrhage or hemolysis here, the question can be answered more with a clinical history and the clinical findings, unless we talk about a chronic external hemorrhage and we have this sort of microcytic hypochromic because of the iron deficiency. And then we have all these sort of morphological abnormalities with the hemolysis, with the immune-mediated, the oxidative hemolysis, and the mechanical damage, the toxic neutrophils and the left shift for the overwhelming active inflammation, the blasts and the other weird cells for the neoplastic process being present, and then the ways that we can pick up parasites and, of course, evaluate the platelets. And with that, I would like to thank you for staying with me all this evening. And of course, if you have any questions, I'll be happy to answer them.
Kostas, thank you so much for your presentation. That's been absolutely brilliant, and thank you to everybody who's stayed with us. That's been really enlightening. We loved all of the images. You must have spent a long time putting all of those together, and the interactive case studies were brilliant. I could tell from the number of people that we've got signed in and the number of answers we were getting. There were a few people who were a bit shy there. I don't know if I'm assuming it was anonymized, so we can't
Yes,
see.
it is anonymized.
Okay, so no need for shyness, but
nope.
That was the first time we've introduced an interactive element to the presentation. But I was participating, and I have to say I really enjoyed it. So I hope that the audience did as well. So very informative, entertaining presentation that you've given us there, a subject that you're clearly very, very passionate about. If any of the audience do have questions, I know that we've gone a bit over time, but Kostas has agreed that he's very happy to stay on and answer questions that come in from the audience. But also, if anybody's watching back after the live event, you do have email details on screen. You can contact us via the website or via email, and we are pleased to pass on any specific inquiries to Kostas, and then he can respond to them directly also, which is a very kind offer. So thank you for that. So if you do have a question, please feel free to pop it into the chat or the question box that you'll see on the screen. And also, if you would like, if you're attending live, we can provide you with a CPD certificate of attendance. So please pop your email address and your name into the chat, and we can get those sent on in the next few days. So I'll just check what else we've had come in terms of questions. So is there one piece of wisdom that you would give to an RVN, a veterinary nurse who has an interest in haematology?
The thing that I would say is to make sure that does the hematology every day. I know that it is difficult to find the time. I know that there are, and I've talked and spent lots of time talking and teaching and training vet nurses. Quite a few of them, they were lucky to be designated as the laboratory scientists in their clinic, and they were doing only that. But there were lots of vet nurses part of the team that were passionate about the microscope and the morphology and all this sort of detective type of work, and they come to courses and they learn, and clearly they actually put quite a lot of effort in doing that. But then um, you go back to the practice, and specifically after a course, and you drag back into the routine of the things, and you miss your momentum, and things are getting not as they don't flow as they should. So I would say that it is important to keep in touch with the hematology, with the instrument and the microscope. And when if there are interested colleagues, nurses that would like to sort of move into this sort of area, make sure that when the boss sends you to a training course, make sure that before you go to the training course, you have set up the right conditions, that when you come back of the training course, that you will be able to have the time and the means to apply all the things that you learn and the things that you're interested into the practice, and not to sort of like lose the touch. That conversation has to happen before you go to the course, not after. So
Yeah.
that's my tip, is that make sure that if you're gonna continue training, to have a setup with the practice, that when you go back from your training, you are able to do the things that you want to do and you learn about.
Fabulous. Thank you. So keep exercising that muscle then. If you start it, then keep up the
Absolutely.
good work. Yeah.
Absolutely.
I know we were speaking a little bit before the webinar started about recognizing what's right and recognizing what's not right, and it's that practice element of you get the feeling of knowing what looks good and what doesn't look good quite quickly when you've seen that a lot.
Absolutely.
And
Absolutely. Yeah.
we're getting a few questions coming in now, so I'll get through as many of them as we possibly
Yeah.
can. Just around that, looking at slides as well, we saw many images, and we've had a lot of thanks for the brilliant webinar, and the images have really made it come to life. It's really demonstrated the science and the art of veterinary practice also. Just around that, a couple of questions to do with recommendations for looking for a good microscope, your top tips, and also, if you have smears that you would like to submit elsewhere, what's the best way to get a picture that is useful if you, as a pathologist, were having a look at a smear from somebody else?
Yeah. For the microscopes, I think generally there are lots of good microscopes with good quality lenses and mechanic bits, and they are quite sort of like economical as well. I can actually tell you that I have the one that I have next to me. It is not a very expensive one, but is one that actually has quite good quality lenses. Is a Motic microscope, but there are lots of other ones. I would say the price, it's a guidance, and I personally, I believe that if you're spending anything less than sort of £1,000 for a microscope, then you're coming into an area where it's going to be hit and miss. You may get something that it is decent, or you're going to get something that is not particularly good. So this is my ballpark, because it is true, what you pay is what you get. And even with the quite good and less expensive that come from Asia, from the Asian market, still, the £1,000 mark, it is a good sort of like guide where to go with the microscopes. Um, the other thing which is extremely important with the microscope is to keep them in a good shape, clean, and have them sort of serviced once a year, for sure. And regarding the images, I get lots and lots of images for discussion and an opinion, which are taken from the microscope with our mobile phones nowadays. There is so much good quality cameras on the mobile phones that and I know for a fact that vet nurses specifically, they are so good with this type of technologies that I get lots of images from nurses that they take from the microscope with their phone, and that is more than enough quality to actually give some useful information and feedback. The good thing is that with the nurses that are familiar with the morphology and they are involved in the hematology, they are uh, they are good because they get really focused, centered for images, and they say to you, okay, what do you think this is, or is this that, or that, so you know that you get a specific question about that. Now, other images that are more generic and say, do you think that this anemia is regenerative or non-regenerative? Obviously, will require to actually get more images. So what I will say is that if you have a blood smear you want to send for assessment, I would say to actually get at least 5 sort of images from different sort of representative sort of areas of the smear. And if you have specific cells that you want to identify, just to actually get a few of those sort of cells, again, I would say a minimum of 3 to 5 sort of like images from these cells, and send them WhatsApp if you are with your sort of like with the clinical pathologist, or email with WeTransfer is a sort of free sort of way to transfer larger images if they are large. Email works as well. Lots of easy to actually do with email quite a few times. So yeah.
Okay, amazing. That's really helpful, practical advice. And as the recipient, obviously, the better the quality images, the easier your process becomes, and the more helpful you can be.
Absolutely, I have loads of photographs in my library which are brilliant, and they are as good quality as if you had the actual blood smear. And you can actually say lots and lots of things from it. So I would say, yeah, and the more you take photographs and you practice, the better you become at it as well.
Of course. That's brilliant. Thank you. Another question that's come in from one of our attendees this evening is, firstly says, thank you so much. Could you please briefly mention the clinical importance of eosinophilia or monocytosis?
Yeah. With eosinophilia, the key thing that we were thinking will be some type of an allergic disease, a parasitic disease. Mainly these are gonna be external, in the majority of cases, external parasites, ectoparasites, or GI sort of like related, that will give us quite a prominent eosinophilia. Now, moving to a sort of like second tier of diseases that we'll need to consider if we are eliminate the allergic parasitic ones, which are the most common ones. Then we will be start looking into conditions that they are the eosinophilia. It is a result of another process, and common will be to be associated with the neoplasia, and the most common neoplasia that is related to eosinophilia, because the cells talk to each other, is the mast cell tumor with the eosinophilia. There are some lymphomas as well that can do a sort of paraneoplastic eosinophilia. And then we go to the more specific ones that they are more characteristic, let's say in the cat, who have this sort of weird sort of eosinophilic, hypereosinophilic syndromes, and eosinophilic sort of conditions of the cat, where we get all this sort of accumulation of eosinophils in different bits of the different organs of the cat. But that is something which is not as sort of like as common, if you want. So yeah, to summarize, allergic, parasitic, and then the paraneoplastic ones, they're going to be the ones that actually will start as the main ones. Now with the monocytosis is an interesting one, because the monocytes are per se are not they are very important cells, but that they are involved in so many activities, if you want, that there is not a specific disease which gonna be behind the monocytosis. The monocytes, when increased, basically they indicate that we have an inflammatory process that created such a tissue distraction that now the monocytes that will have to actually be have to go there, get into the tissues, change into macrophages, and start eating up and clearing up the mess that is the result, or the process of this inflammatory, infectious, neoplastic type of disease. So the monocytosis is indicative of a disease process involved with inflammation, infection, neoplasia, immune mediated. So it can be anything, not a specific one. Some people say that the monocytosis also indicates a chronicity, that it is an inflammatory or infectious or neoplastic process that's happening for some time, which is true in some cases, but in some others isn't, because you can actually have a very acute, intense inflammatory process, and the monocytes within 18 hours will move from the marrow and will be into the tissues very, very, very quickly. So with the monocytes is more the intensity of the inflammation that actually drags them and activates them, rather than necessarily the chronic duration.
Okay, so it's part of a much bigger picture then with the monocytosis. Look at a lot of other things as well as what you're seeing from the machine, or more likely from your smear.
Yeah.
Okay, that's a great explanation. Thank you. And then I think we're down to our last question now, unless anybody's got anything last minute. Regarding overwhelming inflammation, do we have similar biomarker of inflammation such as CRP or ESR, roller erythrocyte formation, marking significant inflammation? Is there species-specific difference with inflammatory biomarkers?
Yeah, that's a great question, it does bring us to the the concept that we're actually saying, that just the instruments and the numbers is not the full does not give us the full picture. If we do have left shift and we have toxic neutrophils, the likelihood is that we have a systemic inflammatory response, which means that the other biomarkers that we mentioned, like the acute phase proteins, they will be there as well. Now, the biomarkers of the acute phase proteins as biomarkers of inflammation, of systemic inflammation, are extremely important, and there are differences in the species of different proteins. The CRP, C-reactive protein in the dog, it's a major acute phase protein marker, inflammatory marker. The serum amyloid A and alpha-1 glycoprotein in the cat are big ones and very, very important. The thing with these proteins is that they are they're going to be produced with the inflammation, systemic inflammation is happening, or will pick up, and then they're going to drop down as well as the inflammation goes. And the as that happens, the neutrophil count can be absolutely normal. So you can actually have a systemic disease where the there is active inflammation, there is production of these proteins from the hepatocytes, and the hematology can be absolutely normal.
Okay, that's great, thank you. And just to touch on that as well, a bit of a plug for HORIBA CPD. We do have a previous webinar on inflammatory processes with another brilliant speaker, Kit Sturgis, who spoke for that previously. So if you have a look on the HORIBA Veterinary website, the library of webinars there, amongst a lot of other things, including hemostasis, FIP, blood transfusions, there is an inflammatory diseases webinar there, which touches on exactly those things. So I believe we've come to the end of the questions now. So Kostas, thank you so much for giving us your extra time and your really in-depth answers to the questions that have come in from our delegates there. So as mentioned, if there are any questions that spring to mind later, or if you're watching back, please feel free to email us or get in touch by other means. If the HORIBA team can help you, we will, or if we need to pass on something to Kostas, we're very happy to do that. He's also available. You probably wouldn't have too much trouble tracking him down if you wanted to find him, I think, but he's been very generous with his time this evening and also with sharing additional information. So thank you to everybody that's joined us live or is watching back, to Kostas for his time, and also a quick thank you to the HORIBA team who make these webinars happen, from the advertising, the registration process, and my colleague who's doing the recording. And we've all stayed up after a long day to get this out to you today. So thank you to everybody. We will be at some forthcoming commercial events. So if you're going to BVA Live or BEVA Congress or London Vet Show, please come and say hello on the HORIBA stand. We would love to see you. And you can also follow us on X and on LinkedIn, where you will find our newsletters and any forthcoming CPD. We have an equine webinar coming up in May, so you'll see that coming out soon. So that just remains for me to thank everybody, the attendees, to Kostas and to the HORIBA team, and wish you a very good rest of your day. Thank you.
Thank you very much.